I
Yeah.
think let's get started. So thank you everybody for joining us today for the topic on people with lived experience regarding harm reduction. And I feel super privileged to be hosting this webinar with all of you. My name is Elza Berk. It says Elizabeth Berk, but I'm Elza Berk, and I'm a person that uses substances, and I also have mental health struggles regarding anxiety and depression and ADHD, and struggle with PTSD. And I'm going to be moderating this session. And I'm so grateful to have these three amazing individuals with us today. Do you guys just quickly want to introduce yourselves? Whoever would like to start?
Hi, everyone. My name is Charne Roberts. I am from the South African Network of People Use Drugs, and I am the National Advocacy Officer, and so glad to be part of this webinar today.
Hi, everybody. My name's Julie MacDonnell. Great privilege to be here this evening and chatting to everybody. I am a consultant in South Africa, in Cape Town, working with human rights, harm reduction, and healthcare. I'm looking forward to this evening and sharing our stories with you. Thank you.
Hi everyone, my name is Susan Wambui. I'm a woman with a history of drug use, a harm reduction expert, from Kenya. I'm super excited this evening for this webinar. Thank you.
Thank you, everyone.
And I've forgotten from the Kenya Network of People Who Use Drugs, a women representative and also a co-founder of a community advocacy initiative that is community-led organization that does advocacy. Thank you.
Thank you. So harm reduction, in my understanding, is a compassionate, person-centered approach that prioritizes individual safety, health, and dignity. And thanks to these three amazing women, we are going to be talking a bit more about it tonight. And we're going to be starting with Julie and just her extensive experience working with vulnerable women and priority populations in rural areas. And just to look at some of the unique challenges that these communities face when it comes to harm reduction and how policies can be better adapted in these areas.
Yeah, hi everybody. It's lovely to be here, as I said. So I'll dive right into it. So obviously where harm reduction is concerned and we're providing services to people who use drugs and vulnerable women are, we have different needs in metro areas as opposed to rural areas. And working with rural women really is my passion. And vulnerable women. So I think I'd just like to highlight so some of the challenges that rural and women living in remote areas experience. First of all would be the lack of services. For many of the women, there's only one clinic or healthcare facility in a town. And I think one of the major challenges they face is that most of the people that are working in the clinic are very well known in the community, and that causes significant distrust in terms of confidentiality. The person who is perhaps one of the nurses at the clinic could be the person who's living next door, or it could be the sister of your neighbor. And so a lot of women particularly young women, are very fearful of going and accessing healthcare services because they worry about their either their mental health issues or their drug use issues, or contraception issues, if they're pregnant or not, or their HIV status. They worry significantly about that being made public. We also see in rural areas, there's still in certain areas in South Africa, still quite a strong focus on traditional healers. And women will tend to go to traditional healers or even religious leaders first before accessing healthcare services. So with harm reduction, we have a slightly different approach in that we try have an all-encompassing approach. We don't say that they have to go to clinics or they have to access healthcare services first. We try work through traditional healers as well. We work with faith-based leaders and with religious leaders so that we can provide access to well, we can reach these women, you know, as for however way we can in communities. And then, yeah, just one of the other things that we find that there's a much higher prevalence of gender-based violence and intimate partner violence in rural and remote areas compared to that in urban areas, and the reporting of that is significantly lower. Those are kind of key things to bear in mind as we're talking about harm reduction today, just that some women face a lot more challenges than those in the more urban or peri-urban areas. Yeah.
Thanks, Julie. So with the harm reduction strategies, is to advocate for evidence-based harm reduction approaches in these challenging environments.
Yeah, so one of the big things I feel we really should be doing, can everybody hear me? Sorry, it's being unstable. Can you hear me? Yeah. So yeah, one of the issues, I think we really need to be advocating at high level engagements for community orientated care. So that's essentially having programs that are based in communities and employ and capacitate members from within the communities who understand their context. It's also critical that capacitation on harm reduction is carried out on a broader scale, meeting with global practices and sharing some of that global practice information with local communities so that we can grow the harm reduction space, you know, on the political sphere, and also to get that more implemented at a governmental level. And then also just, yeah, to educate people on the fundamentals and the principles of harm reduction, and not for people to kind of lower the fear. There are a lot of people who don't understand harm reduction, and therefore there's a bit of fear around that. And the more we can educate and capacitate communities and leaders, as you know, as well as government at national and district level, the greater we can spread harm reduction, or the greater we can reach harm reduction into the communities. Yeah.
Thanks, Julie. Does harm reduction only apply to substances, or would you?
No, so you know, I'll take you through some of the principles. Fundamentally, harm reduction is a set of principles, sorry, that focus on reducing or mitigating harms to individuals or their communities in which they live. So just a basic example, I always like to kind of use an example that everyone can relate to, and that harm reduction is something like having a speed bump on a busy road. It's not saying that you're going to stop having accidents altogether, but we're going to mitigate the risk by slowing people down. And basically, if you can grasp that concept, the same could be said for wearing sunblock or putting on a seatbelt or using condoms. We're not saying that we are eradicating the risk completely, but we're putting steps in place to mitigate that risk. And so when it comes to substance use, we have there's sort of 5 key principles that we like to consider for people who are using drugs. And people that would engage in harm reduction would be people that are not ready to stop using completely. They may be on a journey towards stopping, they may not be ready to stop yet. And so we say, right, let's meet them where they're at. And let's see how we can help them still. How can we reduce the risk of their substance use behavior? How can we reduce harms? And so we focus on the individual's well-being as the criteria for success, and not their drug use. We ensure that people who use drugs and those with a history of drug use have a real voice in creating programs that concern them. We don't believe in the kind of harm reduction space that we'll just follow, say, for instance, European best practice. We like to look globally, including African context, of what really works for the people who use drugs in our context. We recognize that poverty, class, racism, social isolation, trauma, sexual-based discrimination, etc., all influences people's vulnerability to effectively deal with drug use disorders, and that it's not just a matter of them wanting to stop or their will to stop. We also understand that drug use and behavioral problems are complex, multifaceted, and that it encompasses behaviors that from severe to total abstinence. And we acknowledge that some ways of using drugs are safer than others. We also affirm that people are the agents of their own change. And I think this is something really critical today. Yeah, but we ideally want people to be reducing harms to themselves, but forcing somebody to stop using drugs is never going to be sustainable. So with a harm reduction approach, we really recognize that people are the agents of their own change, and that empowering them and sharing information and support with them is far more helpful than isolating them or sending them away for treatment. Harm reduction also does not minimize or ignore the real danger that is associated with illicit drug use and alcohol. And that's something as simple as encouraging someone who is perhaps drinking heavily to start reducing the number of units that they consume every day, maybe from 8 to 6. This is already a harm reduction intervention. Harm reduction does not need to be complicated. It can be something very simple. And yeah, from my perspective, it's all about giving hope, especially to women. Thanks very much.
Thanks, Julie. Yeah, I love that, because I also think, I mean, I often say to people when they ask me what exactly is harm reduction, I say it's a bit like putting a seatbelt on. When you're in a car, you're putting the seatbelt on just to mitigate the risk of if you get in a car accident, you don't get hurt. That's it. Like,
Absolutely.
you put the seatbelt
That's
on.
the basic principle. If we can understand that, it's accepting that if we can reduce, we can't stop the accidents from happening. So we can't stop drug use from being dangerous, but we can reduce the risk to the individual and to the people around them. Yeah. Thanks.
I think that's, you've given some really valid points, which I think really like shifts, especially thinking around substance use, where I think a lot of people do get stuck around the abstinence-based model, where it's like you have to be able to stop. But if we look at it from a mental health point of view, and from, you know, it's not a choice. And I think a lot of people get stuck that it is a choice. So I think you've really given some valuable pointers there. Thank you so much.
Pleasure. Thanks for having me here to chat. Thanks.
Anytime. Our next presenter is Charne Roberts. Do you want to just tell us a bit about you and how you got here and how you got into harm reduction?
I'll do just that. Thank you so much. So as mentioned, my name is Charne. I have lived experience as a woman using drugs. Growing up, I really faced significant childhood trauma, including molestation. In my adult years, I experienced a lot of gender-based violence and trauma of losing loved ones due to murder and my house being completely burnt down. I lost my two nephews. It's these factors that really led me to problematic substance use, severe anxiety, and also self-harm, like self-infliction of pain. I struggled with mental health, and at some point I felt that drugs were my only real escape from the pain. I also do feel, had it not been for that escape, had it not been for the drug at the time, that I probably would have committed suicide, because I needed a place to take me away from my realities. I was not able to deal with these problems. And I know people are very judgmental, but in a strange way, my substance use at that point really saved me from killing myself. It took me out of my reality, because as I mentioned, I was not ready to deal. And then my turning point for me was basically motherhood. Once I became a mother, I knew that I needed to change. I started seeking information and I discovered the Harm Reduction Center. It's at the Harm Reduction Center where I joined support groups for women use drugs. And these support groups played a vital role in helping me face my challenges. Through the years of practicing harm reduction over a long period of time, I've significantly reduced my substance use to a point where it's no longer a coping mechanism for me. So that is just a brief background to Charne. Charne was not always the National Advocacy Officer for SANPUD. I also have that lived experience of trauma, and it took me a long time to really work through it. And that's why I am where I am today, and why I want to work in a space where I can motivate women who have similar challenges like I have. Okay, so that's my bit of background.
Oh, thank you so much. I mean, thank you so much for your vulnerability and sharing all of that. That's absolutely, life-changing stuff that you are sharing. And I think one of the big things that that I've really picked up from that is that it does take a long time. And there is not necessarily a quick fix where people are like, no, it should just, you should just get to grips with it. And it does really take a long time. And just, your vulnerability. And I can so relate to this suicide. Like, I really do believe my substance use saved my life for a really, really long time. That's all I had to lean on. So, so thank you for, just being so absolutely vulnerable and sharing that and being a spokesperson for women. So I just really, that was incredible. Thank you, Charne. With your advocacy work, focusing on the rights of people who use drugs, particularly women, what are some of the biggest misconceptions about women who use drugs, and how do these myths impact policy and support services?
So having lived experience as a woman using drugs and also working with women using drugs, I know that there are plenty of misconceptions. Some of them, I'll mention a few, mostly being that women use drugs are bad mothers. This is one of the most harmful myths. Many women use drugs are loving and committed mothers, yet they often face punishment and child removal simply because they use drugs. To address this issue, SANPUD hosted a Bridging the Gaps event where social workers and mothers use drugs. Many mothers attended this event seeking clarity on their rights and exploring support options beyond child removal. It was in that space that I actually learned for the first time that a lot of social workers also experience a lot of stigma, and they are often misunderstood. But genuinely, as the social worker mentioned, they really want to support families. I think the engagement we had with social workers provided valuable insights to both the rights of mothers and the procedures that social workers follow. And I think it was a very meaningful two-way learning experience for both parties involved. Another one of the big myths that that people often speak about is that women use drugs are always trading sex for drugs. Not all women who use drugs are sex workers, and not all sex workers are women who use drugs. I know that there are times when there are intersectionalities, but this is something that should not always be assumed. And then I think one of the important ones that's very close to me is that women don't want help. They don't care about their health. Now, I know for a fact that women do want support, but they fear judgment, they fear losing custody, they fear being re-traumatized. In reality, many women who use drugs are managing very complex lives. They need to care for family, they need to navigate through violence, poverty, and criminalization. The drug use is one part of a bigger picture and through all of that, women still show incredible resilience in the face of that all. Just to give a bit of example what the work that SANPUD does. So at SANPUD's health events, we've seen high turnouts of women seeking services for cervical cancer, screening, pap smears, HIV, and STI checkups. Often the reason why women don't go is the fear that they might be stigmatized or discriminated against. And I know that SANPUD has worked very hard to close these gaps through our community-led monitoring, through our trainings, and through our strong relationship building with healthcare providers to ensure that the community are able to access services and that they feel very welcome. With negative myths of women use drugs, like seeing them as bad mothers or morally weak, it creates stigma, it limits the access to help. it leads to policies that ignore their needs. This then results in poor punishment than support, making it harder for them to actually get the support that they need.
Wow, thank you, Charne. That's a lot. And I think most women can relate to all of those fears. Do you know what I mean? If we think about it, like those are all, we've either heard of someone that's gone through it or we've gone through it ourselves. So thank you so much for that. Campaigns like Fem Alive and Support Don't Punish aim to shift narratives around drug use and harm reduction. What strategies have you found most effective in mobilizing communities and stakeholders? I mean, I think you've named a couple now already when you spoke about those campaigns that you spoke about.
Okay, so I think just to give some context to the campaigns, so the Support Don't Punish campaign advocates for drug policies grounded in health, human rights, harm reduction over punishment. It calls to end criminalization for people who use drugs and promotes increased access to support, care, and evidence-based services. Okay, so with the Fem Alive campaign, which is something that I established, the campaign that I formed, it focuses on advocating against gender-based violence, severe human rights violations faced by women who uses drugs. And the key aim of this campaign is to effectively connect the community to the services that they need. So for community mobilization, our SANPUD community linkage officers plays a very critical role in informing the community about these campaigns and encouraging them to participate. This ensures, by them participating, it ensures that their voices are being heard and also that we are able to address the challenges that they are facing. In terms of stakeholders, we share all our campaign information via our various platforms. We also include it on our SANPUD communications list. And we also maintain ongoing relationship building with police, integrating them into our efforts through continuous dignity and diversity trainings.
Wow, that is a lot. Like that is a lot of work. So yeah, once again, well done. I mean, that's massive advocating. Well done.
Thank you so much.
Even though criminalization continues to be a significant barrier to harm reduction, how could decriminalization improve outcomes for people who use drugs, particularly I would say in South Africa, because that's we are
focus.
Yeah.
Okay, so I think like if we look at Portugal's model, so Portugal decriminalized drug use in 2001. This resulted in lower overdose of deaths and also the reduction of HIV transmission and increased access to treatment and not punishment. So I think if South Africa was to decriminalize drugs for personal use, people would no longer face a longer jail time, and this would ease pressure off the justice system. Without fear of being arrested, more individuals would actually seek medical help, improving health access. Resources could be redirected from policing to vital harm reduction services like our opioid substitution therapy and like our methadone programs. And it would also open more employment opportunities for the community of people who use drugs. And I think most importantly, it would definitely reduce stigma, discrimination, and human rights violations. Thank you.
Thank you. Yeah, it's a lot of work that we still need to do in our country, but I mean, you guys are massively advocating for it all the time and working super hard to make sure that we do actually get there at some point. So once again, thank you so much. We are going to move on to Susan. So it's Susan, sorry, I'm in the Afrikaans world at the moment. Susan,
Okay.
Susan, do you want to introduce yourself, or would you like me to just jump into some of the questions? What do you feel most comfortable with?
I can introduce myself. Then we go back. We go to the question. And apology, my internet is shaking. I had said it earlier. So when
Don't-
my video is on. So Susan Wambui is my name. I'm a beneficiary of harm reduction intervention in Kenya, a founder member of Community Advocacy Initiative in Kenya. It's a community-led organization that is led by paralegals, and a steering committee member of Kenya Network of People Who Use Drugs, the national network, now the women wing. So I'm very passionate about women, and more so women and their children. So I'm deeply committed to advocating for the rights of people who use drugs holistically, not only women, but both women and men. Thank you.
Thank you, Susan. As someone with lived experience, you bring a unique and powerful perspective. I mean, I think it's really, especially around harm reduction advocacy. What do you believe policymakers and healthcare providers often misunderstand about the realities of drug use and harm reduction?
So as a woman with a lived experience, one of the things that policymakers and healthcare providers misunderstand about drug use and women who use drugs and the issues of drugs is the issue of the mental health and the traumas that comes with the drug use. Earlier, one of our colleagues has talked about her journey in the drug use. So most of the time that healthcare providers and policymakers, people in the space don't understand is that one of the misunderstanding of policymakers is that failing to recognize the rates of trauma that women who use drugs experience. Most of the time they see drug use as primarily problem rather than a coping mechanism. So that, like she said, that I don't have to relate in sex work and drug use, that I don't have to be a sex worker because I'm a drug user. And the reality is that many women who use drugs is a direct trauma, and harm reduction sometimes need to be trauma informed, because many women who use drugs go through a lot of trauma, and the accept of trauma in harm reduction most of the time is not included. So that we can know the root cause of the drug use. And for the advocacy perspective is that we need policies integrated. And these policies to be integrated in harm reduction need to be, like I said, trauma informed. And we also need to include the aspect of mental health supports, safe housing. As a woman with lived experience, my unique perspective on harm reduction advocacy is the power of community, emphasizing on community, on safe only women spaces. Because most of the time the harm reduction space is male dominant. We've seen, and I want to quote it, in many spaces that we've seen male in leadership. And so we need a safe space for women. And why do I say a safe space for women? Because we need to address the gender power dynamics that comes with violence. Because many women who use drugs have experienced, like I said, the trauma, and women-only spaces can provide these powerful dynamics, fostering trust and safe. So yeah, that's my take.
Thank you, Susan. You are very involved, and we're going to go to questions right at the end. So anybody that has questions, I'm seeing some questions popping up as well in the chats. We will go to the questions at the end, so everyone just hold tight, I promise. I just wanted to Susan, to just ask you, because you're involved with CAIK. Sorry, I'm very
KAIK, Community Advocacy Initiative.
yes, and KENPUT, which focuses
KENPUT.
on community-led initiatives. In your experience, why is it essential for harm reduction efforts to be community-driven, and what impact have you seen when people who use drugs lead these initiatives?
So community-driven harm reduction, where people who use drugs are leaders, is very essential because people who use drugs are the experts with their own lived experience. And so the leadership will lead to better understanding of the context and needs of people who use drugs, increased trust and engagement with service, the harm reduction services, because even as someone with the lived experience have their way of bringing their peers into the services. We also need development of relevant and acceptable solution. This will lead to that when it is led by the community themselves. They are tangible, they are solutions that are seen. And there's empowerment that reduces stigma. And more sustainable and impactful initiative like the initiative that we have, the KENPUD and the KAIK, and so many community-led organizations. The solution they bring, they are more sustainable because it's a lived experience. So my work with KENPUD and KAIK shows that community-led effort result to greater services uptake. My work as a community leader to mobilize, to link community members to service provider, because we don't provide services, but we are the link to the service, to the mat clinic, has improved the healthcare and outcomes and stronger advocacy. So, and also even to policy change. Thank you.
Thank you, Susan. A huge part of what we're also looking at when it comes to substance use is criminalization, and stigma remain still the major barriers to harm reduction. From your work as a community paralegal, can you share a powerful example of how legal advocacy has made a difference in the lives of people who use drugs in Kenya?
So as a community paralegal in Kenya, I've seen and I've experienced how criminalization and stigma severely block and has blocked harm reduction services. And so legal advocacy, in the introduction of paralegal to do advocacy for the harm reduction, legal advocacy has made a difference by challenging arbitrary arrest. And when I talk about arbitrary arrest, I mean that this is the arrest and detention of the individual without legal justification and due process. So my work as a paralegal and legal advocacy has challenged that, and also advocating for harm reduction as a public health, not a criminal offense. It's a health like any other health issue. So, because initially drug, and especially in my country, minor drug-related arrest could lead to stigma. And even now it's leading to stigma. Disruption, for example, if I'm on methadone, mat clinic, and I'm arrested, or I'm taking my ARTs at the clinic. So the services are interrupted. And then also you get that there is overcrowding in prisons because of cases which could have been handled out of prisons. And this has caused to more serious issues, even the health issues for people with drugs, being placed to prison, being arrested, they further strain health-wise. So also waste of resources. So as a paralegal, my coming in is an advocating has often and is often leading to challenging unlawful arrest, sensitizing law enforcers, advocating for policy change, strategic litigation. We do Know Your Rights campaign. We do legal aid clinic. We are working closely with pro bono advocates, supporting my community, our community member, even through the court process. As much as I'm not an advocate, but I will support this person through the court. We know for our community, most of the time it is escorted referral. For a community member, they need an escorted referral. So as a community paralegal, it is my responsibility. And powerful example of how legal advocacy has made tangible difference in the lives of people with drugs in Kenya, involving the work around challenging the illegal arrest and advocating for policy change. For example, in Kenya, initially, Panafan areas, one could be arrested, even a peer educator, carrying the syringes and the paraphernalia used to that are using drugs, they could be arrested. So, but for now, because of advocacy, there's no arrest in that. So yeah, we are keeping our work as paralegals, and my work is to keep advocating for change of laws and policies. Thank you.
I always forget to unmute myself. What I'm really hearing is the holistic way of looking at people that use substances and looking at it from the point of view as the person as a whole, instead of breaking people up into you using substances and this is what's going to happen, which is why you're saying where you're really talking about from a legal point of view, looking more at the Portugal model, if we want to put it like that.
Yeah,
that makes sense. I just wanted to, there's a whole bunch of questions that have popped up, and thank you so much to our three amazing individuals that have come to talk to us. Sandra, do you want to go through the questions, or can I?
Oh, you can, excuse me. You caught me off guard there, it's something in my throat. You can go through them if you're happy to. I'm posting some on the chat as well.
Oh, okay, cool.
Are you comfortable with that?
Yeah, it's fine. I'll go for it. So someone's asked, how does a partner or family member deal with someone who uses drugs if they're finding it challenging in a harm reduction kind of way? And I think that's a really important question, because from stigma point of view, all of it, anyone's welcome to answer it. Who feels comfortable to answer it?
I'm happy to start. I'm sure Charne can add, or Susan can add to it as well. But yeah, I think the main thing is just to constantly keep seeking the human in the person, and to try lose the bias or try lose the thinking that this is a choice that they're making, and to start to understand that this is a challenging situation. It's complicated. And although I don't like to glorify the medical model or say this is a disease model, but to help people just to kind of frame it, if this person was suffering from another mental health condition, how would you like them to be treated, or how would you treat them if it wasn't drugs? Because I think we demonize the drug, we make the drug the problem, and that at the risk of not actually looking at what are the complexities. We just say, oh, they're on drugs, therefore drugs are the problem. But there could be a whole lot of other complexities. And when we start looking at it collaboratively, we can generally, there's always something that can be done. And that's the beauty of harm reduction. They don't have to stop immediately. We can start reducing the amount they use. We can reduce the way in which they use, there's so many small ways that we can actually start the process of harm reduction. So that's from my side. Charne and Susan, if you want to add.
I think, I agree with what you were saying, Julie. I think when it comes to substance use, there is a lot of underlying issues. It's almost like an onion that you need to unpeel the layers to find out what the root cause of the situation is. And I do find, like, within the Harm Reduction Center, having psychosocial counseling with parents or family members included is very important, because I know that it is sometimes very difficult for family members to understand how to deal with someone using drugs. So once you educate yourself and once you start attending counseling along with the person who has a substance use disorder, it makes it a lot easier for you to assist. Because I do know that exclusion is never really the way to go. Pushing people out and excluding them, it does not help the situation at all. And that is why we go with the motto, support, don't punish. I know it may be, it's sometimes very hard for families, especially if you disappointed them more than once. But I mean, it is a process, and harm reduction is a tailor-made process according to the person itself. So I would say that family counseling, psychosocial support with the family is very important, and just trying to understand, instead of just excluding them or cutting them out, let's try to assist, and that's the motto, support, don't punish. Thank you.
Thank you so much. I'm just going to jump on to the next question. Great presentation. Can someone please speak to the misinformation, exaggeration on the effects of drugs on the fetus, which makes pregnant women who use drugs experience another level of stigma from healthcare workers? Anybody?
I think that Julie.
Yeah, so this is the area I'm most passionate about. And I think there are, whoever raised that question, thank you. There are so many myths and difficult for us. I mean, I think we could do a whole webinar on that by itself. But I think what is just really important to mention is that it's actually the two substances that are legalized that are the most harmful to infants, and that would be or harmful to pregnancies, and that would be nicotine and cigarettes as well as alcohol. Those are the two substances that do the most damage. And the misconceptions are that heroin is so dangerous and methamphetamine is so dangerous, but the damage long term on the infant, on neonatal pregnancy, is definitely nicotine and alcohol are the most harmful. So that's one of the biggest myths. The other myth is that if you are using drugs, you shouldn't be breast or chest feeding. Recent evidence has shown that certain drugs, it's perfectly fine to be chest feeding. There are also some wonderful ways. We use the term pump and dump. So if you have recently used drugs, to pump that milk and dump it, and then to be able to continue breastfeeding thereafter. But yeah, if anybody would like specific information on pregnancy or has specific questions, please reach out to me directly. And I'd be more than happy to share information on that. Thank you.
Thank you, Julie. Next question is, one speaker, which was me, said that drug use is not a choice. Are we making the assumption that there are no people who use drugs because they want to? My concern is that this may be pathologizing people who use drugs, which may add another layer of stigma to people who use drugs, as sick people who are not capable of leading their own issues.
So I do think that not all substance use is problematic substance use. Some people make conscious decisions to use drugs, but I think it becomes problematic when they are not functional, or when their substance use starts to affect other parties in their lives. I think that's when it really becomes a problem. But I know that there are people that will occasionally use substances to have fun, to enjoy their weekends, to go to certain rave parties, but they don't use it as coping mechanisms. And it's not something that they use daily. It's, in moderation, or when the feeling hits, I suppose. Yeah. So I think people do use it. It's not always problematic, but they make a conscious decision too. and they are also very functional when they use it. Yeah.
Everyone happy with that? All good? Okay. It seems that harm reduction is very much evidence-based. So what are the biggest challenges beyond legislation and stigma, and how can we as a mental health community support harm reduction services?
I think the most important thing, I think, for everybody is to learn as much as you possibly can about harm reduction, to educate yourself, to capacitate yourself. Harm reduction is we don't like to think of it as a treatment model. It is a lifestyle model. And it is something that can potentially work for anybody, even if abstinence is your outcome or your goal. Even if you're working towards that, you can still have a harm reduction approach to getting to abstinence. And I think, it is grounded very much in policy change. And also just to mention that Africa is still quite far behind when it comes to harm reduction approaches. When we look at other countries around the world, even other third world countries, for instance, Brazil's been practicing harm reduction for over 38 years already. And so it's something that's new and scary, or new and challenging in terms of, certainly in South Africa, and I think in a lot of other African countries. But it's the more we can educate ourselves, the more we can learn about global best practice, the more we can learn about evidence-informed information, the easier it will become to implement in our communities.
And also the more we learn even from the lived experience, because they are the experts, it's also makes it more understandable.
Charne, did you want to add something?
No, yeah, I agree with what Julie was saying. And yeah, I'm good.
Well, it's
Sorry.
fine. You just popped. No, it's fine. You just popped up. No, because I mean, I think that was the last. Oh, there's another question. In fact, one of the interventions of harm reduction in mental health support, we need mental health interventions in harm reduction just to ensure we do not assume that all people who use drugs need psychiatric care. There is often misconception that all people who use drugs are mental health patients. So I think, yeah. Sorry, Sandra?
Thanks. I just have some general comments, not so much question. They are probably going to be, there's probably going to be a question in there. But I think what I heard so strongly is the impact you all have within your communities, and the fact that you collaborate with traditional healers, with police services, and on the ground service users as well. And I find it quite ironic in a sense, obviously working at a mental health organization, and the interaction that we have from a mental health perspective, I feel it's almost not as advanced as harm reduction from a South African perspective in terms of collaboration with community and service users and police and that kind of thing. And we know that it is incredibly impactful when you can engage, people with lived experience, and specifically traditional healers. I think it's something that's very much overlooked within the mental health landscape as well. And I think a lot of work has to be done there, not only from a South African perspective, but I think from a culturally relevant perspective globally. And so this is where the question is now going to come in. Sometimes it's just, I have to speak through it, but like in terms of how you did it, how you engaged, because it seems like you have very strong relationships within the community. Obviously, as I see now or understand and believe that harm reduction is about human rights and dignity as well. It's not a case of is it a choice, not a choice. It's not even that. It's a human right. So how can we as mental health organizations kind of not follow route, but how did you do that is basically what I'm asking in layman's terms. And how do we collaborate with those kinds of local community members, etc. And that also comes from a personal, from a lived experience perspective. Having been in mental health systems and stuff, there were very few, if at all, in community services that could assist. Sorry, that was a little bit long-winded.
I think what's really important is to understand from one of the things that harm reduction really respects is poverty. And when we start looking at service delivery in areas of impoverished people, we started to realize that everybody was expected to travel to services. Everyone was expected to find money to pay for services or to contribute towards services. And I think harm reduction shifted that narrative completely by saying we need to get the services to the people as opposed to expecting people to come to the services. And so we started looking at community-oriented primary care, where you utilize the services that are already existing, like public health clinics, like engaging with police stations, and you start looking at how can you embed the information and how can you do community-based care with a harm reduction approach in these structures that are already existing. And that allowed us access to faith-based leaders, to traditional leaders, but it is a process. Yeah, I'm interested to hear what Susan says in Kenya, but certainly in South Africa, it's been a real process of working with municipalities, working at a district level, not working from national down, but rather working really small community, then local, municipal, then district, then provincial, then only national. So that by the time it gets to national, it's really embedded in Department of Health or Department of Social Services. But yeah, I'm really keen to hear what Susan says about Kenya.
So I think we need to have voluntary and person-centered mental health support for people who use drugs. Should be voluntary and tailored to individuals' specific needs and goals, and respecting autonomy and rights of self-determinant. Should not be integrated and a mandatory linkage, because for myself, I think mental health services should be integrated within the harm reduction services so that they can be accessible to persons who use drugs, and should be received with the harm reductions intervention as part of harm reduction interventions. Thank you.
Thank you, Susan. Sandra, is your hand still up?
It is, of course.
Oh, okay.
A relatively easy and not so long-winded one, I hope. But if there's anyone on this call or anyone that might watch this recording and, you know, are struggling with substances, and perhaps it's the first time they're hearing of harm reduction, where do they go? Where do they find resources? I know it could be anyone globally, but let's talk to the context, South African context or Kenyan context. How do they reach out for help?
So I think with SANPUD, there's always the info@SANPUD email address that you could email, and we could necessarily link you to the relevant organizations. I didn't really. What's your thoughts? Okay.
Julie's
Yeah, I think we do have several different organizations in South Africa in different areas. Unfortunately, it's not as many as we'd like, but we do try reach as many as we, you know, get services to as many people as we can. So yeah, I've popped in the chat info@sanpud.org. If anyone would like to reach out privately, we'd be able to link you, or we'll try link you with services in your area. Thanks.
Sorry, I'm just, yeah, everyone's just congratulating. So, yeah, because I want to, part of what my drive for harm reduction has really been, and when I joined the Global Mental Health Peer Network 2 years ago, was around the fact that when we looked at substance use, there was, especially in South Africa, there was such me coming from years and years and years of working in clinics and in centers where there really is only a one-size-fits-all model, which people couldn't meet. They couldn't meet the criteria because they couldn't stay abstinent. So we really looked, when I was working there, at different options. And that's when really harm reduction came to light for me in 2016, where I was like, I was already practicing harm reduction holistically without even realizing it. So it really just became such a good fit for me in my life around having an eating disorder and around having struggles with other kind of behavioral addictions. So I really just think that harm reduction is incredible because it, like I said, there can't be a one-size-fits-all model. It's an unrealistic expectation. So I just want to thank everybody tonight that was here to talk. We've got 3 minutes left. If there's anybody else that has questions or anything else that they want to say, I just want to add one last bit, which I think all of you did touch on, which is the complexity when it comes to substance use, and the fact that the layer of the onion, that mental health and substance use tie in, trauma-informed care ties in. So, and I often hear people say, if we go to the root cause, but the problem I find very often, even for myself, with the root cause is that root cause is also so complex. There's so many layers to that root cause as well, which is why often abstinence for many takes so long, if that is the goal, because they've still got to work through all of that stuff. So with my own individual people that I see is, and for myself, is to not lose hope that even if there was a hiccup or, the seatbelt came off prior to the crash, do you know what I mean? To look at that seatbelt and to look at what was going on with the mechanics in it, and to unpack that instead of writing it all off. And now we have to start all over. And just take a breath. Let's just look at what's going on from a mental health point of view. But Julie, I thought you were typing. So yeah, I just wanted to thank you guys so much for the amazing work that you do and for being part of this webinar. And we've got a minute left if anyone wants to ask any of the three of them for anything.
Hello.
Lucy, yes.
Yes, good evening. I have been following carefully, and I would just like to thank all the speakers. It's really educating. As someone who is part of the Service Users and Family Members Association here in Sierra Leone, our membership is made up of people who have lived experience of drug use, but unfortunately for some of them, they have been diagnosed, I can say wrongly, because of maybe lack of services, or maybe lack of the knowledge, because I'm just learning here now today that not all drug users may be experiencing mental illness. But in the case of some of our team members, they have been diagnosed of mental illness or substance use abuse, maybe way before they got to that level. So I am learning, or I have learned a lot around that here in this meeting. So if I want to add to, I think that was Sandra's question around what can we do as a mental health community to support those suffering from substance use disorder or suffering the discrimination already. My contribution towards that will be normalizing the discussion of harm reduction in the first place in therapies and in educational centers. I think that would be one of the steps to reducing the harm. Let's make these conversations normal. Let people feel comfortable to talk about their struggles. That's just what I would like to add. I thank you.
Thank you, Lucy. I just want to thank everyone. We've got to end. It's 1:06. And yeah, once again, thank you everybody that's joined. And if you want to reach out, Julie has put her details, the email address in the chat box. Otherwise, reach out to the Global Mental Health Peer Network regarding any questions or contacts that you guys would like. And then if anyone is feeling triggered or unsure or not okay after this webinar, please reach out just to maybe to the Sandra's Global Mental Health Peer Network address, and then we will get them some support.
Thank you.
Otherwise, thank you everyone. Bye.
Yeah.
Thanks so
Bye.
much.
Thanks,
Bye,
everyone.
everybody. Thank
Amazing.
you.
Thank
Have a lovely
you.
Easter weekend. Bye.
Oh,
Thank
yes.
you. Thank you.
Yeah,
Happy
Easter
Easter.
weekend.
Bye.
Thank you.
Bye.